Hello and welcome to today's press conference out of WHO at headquarters in Geneva. It's Tuesday, 14 July, and we're shortly after 2 o'clock local time. My name is Christian Lindmer, and we'll be together for this next roughly 1 hour. Today, our speakers will discuss the annual WHO and UNICEF estimates of national immunization coverage, WUENIC, which provide the world's largest and most comprehensive dataset on immunization trends for 195 countries on vaccinations against 13 diseases given through regular health systems, normally at clinics, community centers, outreach services, or health worker visits. For 2025 data, the data were provided from 185 countries, representing 95% of the whole birth cohort. For the non-reporting countries, the 2024 WUENIC estimated coverage was used. Now, let me introduce the speakers, and I'm very glad I'm joined by, first and foremost, Dr. Ephraim T. Lemango. He's the Associate Director for Health and Global Chief of Immunization at UNICEF. He's online with us. Right next to me, I'm glad to have Dr. Kate O'Brien, Director of the Department of Immunization, Vaccines and Biologicals at WHO. Welcome, Kate. And last but not least, we have from Gavi, the Vaccine Alliance, we have Tamani Mafosa, the Chief Country Delivery Officer. Welcome to all three of you. Now, a note on the embargo. All materials presented, and of course what you could already download and receive from us, including this press conference, they are today embargoed until July 15, 001 minute GMT or 2 o'clock Central European summertime, so that's 2 o'clock in Geneva, or tomorrow morning, or tonight still, July 14 at 8 o'clock New York time. So 8 o'clock New York time tonight, or 2 a.m. in Geneva tomorrow morning. Now, you already had a lot of material to download. I know we still owe you the press release, and we're very confident this will reach you before the end of the embargo time. Now, with this, enough of me, and I'm very glad to hand over first to Dr. Lemango. Again, Dr. Ephraim Lemango, Associate Director for Health and Global Chief of Immunization at UNICEF. Over to you, Ephraim.
Thank you very much, Christian. Ladies and gentlemen, members of the press, this year's data shows commendable progress in immunization, but it's still far from enough to reach every child with life-saving vaccines. In 2025, 90% of the world infants got at least one dose of the vaccine against diphtheria, tetanus, and pertussis, or commonly DTP. And 85% completed all three recommended doses. That is nearly 116 million children reached with the first dose and 110 million children completing all three recommended doses. Both figures rose a full percentage point from 2024 levels. The number of zero-dose children, which is those missing on all vaccines, decreased from about 14.2 million in 2024 to 13.5 million in 2025. Countries with significant improvement in their zero-dose numbers include Sudan, India, Brazil, Ethiopia, and Mexico, who have made commendable progress. Compared with 2023 levels, we have about 1 million fewer zero-dose children in 2025. That is real and solid progress thanks to the tireless work and commitment of health workers on the ground, governments, and partners. But it is still not enough. Both DTP numbers, the first and the third dose, are still 1% point below where we stood in 2019. And global coverage has been hovering generally within this same narrow range since 2009. And also the number of zero-dose children that I mentioned earlier has fallen again in 2025. The pace of reduction is too slow to reach the goals by the end of the decade. The 1 percentage point of global progress we are recognizing today masks a considerable inter-country variation as well. Looking underneath this global figure, what we see is 4 clear patterns or group of countries that are emerging. First are countries with fast-growing populations. These are mostly low-income countries in Africa and the Eastern Mediterranean, Every year, more children are born, so health systems have to reach these more children just to keep their coverage rate the same before they can even improve it. The second group of countries are countries facing conflict and fragility. Here, the challenge is simply reaching the children at all. More than half of the world's zero-dose children, or those who are missing in every vaccine, live in these settings. Yet these countries account for only about a third of the world's birth cohort. For example, Syria lost about 6 percentage points on first dose of DTP and 12 percentage points on measles coverage in a single year. Coverage in Yemen remains below 50%. But Sudan shows what is possible when access is improved, even during conflicts. It gained about 35 points on first dose of DTP and 22 points on measles. This is the largest single country improvement anywhere in the world we are reporting this year. Third is a group of countries that are backsliding, and we are seeing a concerning trend in some middle and high-income countries where vaccines are easy to get, but coverage is slipping anyway. These reasons could be structural and governance issues, shifting political will, and rising hesitance and misinformation that all of us need to deal with. For example, South Africa's first DTP dose coverage has fallen by 20 points since 2019 and continued to fall last year. Bosnia and Herzegovina had the region's largest measles coverage gain in 2024. Unfortunately, the very next year, it dropped by about 23 points, which clearly indicates the importance of maintaining program gains and the challenge we have in doing that. Fourth group are the countries making and sustaining progress. It's about 107 of them, which account for about 55% of everyone we track, have already achieved 90% DTP3 coverage. That is the global target for the 2030. It proves that this is achievable and sustainable, and these countries need to continue to sustain that. I want to specifically point to where momentum is the clearest. And these are countries supported by Gavi and the Vaccine Alliance, and my colleague Tabani will speak a bit about it later as well. This year, the global number of zero-dose children fell by almost 750,000 worldwide, and 85% of that drop, to be exact, 640,000 children, came from the lower and lower middle-income countries that are supported by Gavi. In those Gavi-supported countries, DTP first dose coverage rose to 87%, and the third dose increased to 82%, which are remarkable achievements, as in most cases, these countries, the number of children born rises each year. And more than 95 million girls are vaccinated against HPV in Gavi-supported countries over the past 5 years. This surpasses the Alliance's goal of reaching 86 million girls by the end of 2025. In other words, immunization programs in the least wealthy countries of the world are often closing vaccination gaps faster than wealthier ones, while also protecting what they already have achieved and continuing to do more. All in all, this year's coverage is a sign of promising progress and a result of collective effort. But it's also a stark reminder of the enormous task that remains ahead of us to prevent backsliding, protect gains, and continue progress. I'm now handing over to Kate to take us through some of the more specific details of the WUENIC results. Kate, over to you, please.
Yeah, thanks so much, Ephraim. So in addition to the overall coverage improvements and efforts to reduce the number of zero-dose children that Ephraim just described, one of the greatest achievements is that kids today are protected against more diseases than ever. And this is possible because safe and effective vaccines against diseases that were previously not preventable have been developed and licensed and are now in use. This progress has happened over the past 20 years. So this is really a testament to the impact of science and innovation and strong global partnerships. With every new vaccine introduction, including new vaccines against meningitis, rotavirus diarrhea, pneumococcus, malaria, or HPV, and the use of better schedules, such as the second dose of measles vaccine and the addition of inactivated polio vaccines, access to life-giving protection is expanded. So today, the average coverage across a full course of 13 WHO-recommended vaccines against 11 diseases has reached 74% in Gavi-supported countries and 77% in all other countries, a really narrow difference between these two groups of countries and a very good performance. And this metric doesn't include the malaria vaccine, which is early in the introduction phase and has now rolled out in 25 Gavi-supported countries. This is the fastest routine vaccine rollout ever. The gains between 2024 to 2025, as Ephraim has just explained, are modest. But over the past 25 years, and especially since Gavi investment started, these gains are enormous. However, important vaccine introductions and the gaps in coverage remain, and these are what give us concern because the risk of losing these gains and the impact that is not yet realized is still there. So one notable example is hepatitis B birth dose. WHO recommends that the birth dose be given to every baby as soon as possible after birth to protect against what could be lifelong infection, serious liver disease, and eventually liver cancer. Despite its proven impact, just 43% of infants globally receive this hepatitis B birth dose, and only 119 countries have introduced this part of the hepatitis B prevention program. The HPV vaccine, which Ephraim alluded to, is essential to eliminating cervical cancer, and this was provided in 162 countries in 2025. That includes 15 countries in 2025 alone that introduced HPV vaccine. So it's estimated that 33% of girls globally, that's 22.5 million girls, in 2025 received the vaccine through routine services. While still far from that 90% target by 2030, this now represents a substantial increase from only 17% coverage in 2019. If I want to turn to polio now, globally, 86% of infants receive their first inactivated polio vaccine dose, and 74% receive 2 or more doses of IPV. But in 30 countries that have circulating vaccine-derived polio virus, only 65% of infants are fully protected from these IPV doses. For measles, one of the worst and most contagious viruses, the challenge is no longer vaccine introduction. Every country uses measles vaccine, and now every country except for 2 have introduced the second dose of measles, which then provides nearly full protection against the disease. But instead of introduction, the problem here is the failure to get these doses to all children. Ephraim has already spoken about the zero-dose children, those kids who don't get any vaccines at all, including not getting any measles vaccines. But there are other groups of kids, those who get started on vaccine schedules, but as infants, they don't return for their 9-month visit when the first dose of measles vaccine is given. And these children, who we call dropouts, they're known to the immunization program, but they fail to get their first dose of measles, which alone is responsible for 60% of the lives that have been saved by vaccines over the past 50 years. More and more children are starting their vaccine schedules, but are not completing them. And in 2025 alone, 7.3 million infants started their vaccine schedule, but dropped out before they even got their first measles vaccine dose. This leaves millions of children vulnerable to that disease. This dropout phenomenon contributed to stalled measles coverage in another way. Of the 84% of children who received their first dose of measles, we only see that only 77% get the second dose of measles. So at least 95% coverage with these 2 doses is needed to protect communities and protect individuals from measles outbreaks. The consequence is being felt now. 57 countries reported in 2025 large or disruptive measles outbreaks. That's 1 year alone with that number of large and disruptive outbreaks. And these outbreaks are increasing this year, not only from measles, but also now from diphtheria, because kids are being brought in to start their vaccination, but not brought back for all the doses that are needed to actually protect them against diphtheria. So strengthening access and follow-up of immunization services needs to be a renewed priority for every country, so that every child not only starts their program of protection, but actually completes the vaccine schedule in line with their national program, their national schedule, and the Immunization Agenda 2030, which is the world's strategy on immunization. We are off track for IA 2030 goals. It's the halfway point to 2030, and in 2025, 13.5 million children have still not received a single dose of any vaccine. That's nearly 4 million more than the 2025 projected milestone to achieve the ultimate goal in 2030. We have the tools to change this, and what we need now is the commitment to reach every child. WHO and UNICEF are calling on governments, on partners, on communities and families around the world to act with urgency to get the immunization program back on track. First, we must together strengthen immunization services in conflict-affected and fragile settings so that every child can be reached and protected. Second, we must counter false and misleading health information with trusted, fact-based communication. Third, we must increase and maintain both domestic and international investment in immunization programs and partnerships, including fully resourcing Gavi for the 5-year strategy to 2030. And finally, we must invest in stronger data and disease surveillance systems in countries and beyond so that immunization efforts at every clinic is guided by timely, reliable information and points the health worker at every outpost on how to reach those who need the vaccines the most. The tools to protect children from vaccine-preventable diseases already exist. What is needed now is bigger and better commitments, joined up collective action, and the determination by every parent and every health worker and every leader to ensure that no child, no adolescent, no mother, and no adult is left behind to suffer or die from a disease that was vaccine preventable. And with that, I'll turn over to you, Tabani, for your comments.
Thank you, Kate. Thank you, Ephraim, for covering the vast amount of data and insights that have come through. And many thanks to the journalists for their continued interest in immunization. I'm here representing Gavi, the Vaccine Alliance. You'll have heard Kate and Ephraim make repeated references to Gavi. Gavi is a public-private partnership with whom WHO and UNICEF are co-founding members. We support immunization in low and lower middle-income countries, helping vaccinate more than half the world's children. We also help the world respond to infectious disease outbreaks and emergencies. So I want to thank my WHO and UNICEF colleagues for giving me the opportunity to reflect on the unique data that tells us about the state of immunization in these countries and the future ahead of us. Gavi works in 5-year strategic cycles. So this year's unique results are a vital marker to look back at the impact of efforts from 2020 through 2025. Those efforts had the benefit of being fully funded. This year's unique data confirms that remarkable progress can be achieved with sustained investments, political commitment, and true multilateral collaboration. It can be achieved in the toughest contexts and despite the disruptions of the pandemic. In 2025, yet again, lower middle-income countries immunized more children than any other year. Despite the challenges of the increasing birth cohort that Ephraim referred to, DTP1 and DTP3 coverage rates increased. These countries accounted for the vast majority of the global progress in reducing the number of zero-dose children. And as you heard, incredible strides were made in some of the most difficult settings in the world, such as Sudan, that I had the privilege of visiting earlier this year. Vital life-saving progress was made against diseases that take hundreds of thousands of lives each year, such as malaria and HPV, which Kate spoke to as well. I won't go into more detail for those interested in a deeper dive into this year's results for lower income countries. The Gavi media team will share a note following this press conference. But I do want to step away from 2025 for a moment and look back at the past 5 years. As a Vaccine Alliance, we aim to protect 300 million children in lower income countries against a range of diseases between 2020 to 2025. countries far exceeded that target, protecting 351 million children. Each of these numbers represents a child with a healthier, brighter future with access to opportunity. And all of this was achieved despite countries grappling with the worst public health emergency in a century, the COVID pandemic. I'm re-emphasizing these points to remind us all that true life-saving progress is possible when we commit to multilateral approach, governments, donors, international and regional organizations, civil society, academia, industry, we save lives. And we act in our collective interest to keep the world safe from the threat of infectious disease. So as I look ahead to Gavi's next strategic period, Gavi 6.0, as we call it, which runs through the end of the decade, I want to underscore the challenge that is ahead of us. Fiscal pressures, geopolitical tensions, increasing birth cohorts, fragility and conflict, growing numbers of outbreaks and hesitancy. Now is not the time to step back when we know what is possible. At Gavi, we look forward to some countries transitioning away from our support as their economies grow and their health systems strengthen. But we know that we must double down our support in the areas that need it the most. That means ensuring the reach of health systems to meet communities and children, in particular in fragile and humanitarian settings. Ensuring our vaccine stockpiles and innovative finance measures are designed to fight health emergencies are fully funded and operational. Protecting progress and pushing further, that includes realizing the full potential of new and powerful tools, such as the malaria, HPV, and hexavalent vaccines. To meet these objectives, we join our alliance partners, WHO and UNICEF, on calling countries to increase domestic financing for immunization and our donors to fully fund Gavi 6.0. The message is clear, and it is only made clearer by this year's WUENIC data. Vaccines are one of the most cost-effective and impactful investment in health security and prosperity. They save lives, they keep us safe, and they must remain a priority. Christian, thank you. Back to you.
Thank you very much, Dhamani, and thank you to all our three speakers. Now with this, we're opening for question and answers. And again, for getting into the queue for the questions, please raise your hand with the raise your hand icon. And before we get to those, again, the embargo is for another 11.5 hours. But as we're going through the report, we talked about the dropouts, gaps, fiscal pressure, zero-dose kids, political tensions. I'm wondering, is there any good news in this year's WUENIC from the last year's data? And I don't know, maybe want to start in the same order. Dr. Ephraim, maybe from UNICEF. Why don't you start first?
Christian, there is in fact a lot of good news. The fact that I mentioned about the zero-dose number of children that have actually considerably reduced, that is one positive thing to really appreciate. It reduced from about 14.5 million to 13.5 million, and that's quite a significant one when you look at the details from 2023, 2024, and now 2025. And there are countries like India which have been able to achieve quite a considerable progress in reducing not only the number of zero-dose children, but also vaccinating more children against measles. And for the first time over the past, and as much as we remember, for the first time, India is now out of the list of countries with a large number of unvaccinated children. And you would see also countries like Sudan that we just mentioned, where that truly demonstrates that progress is actually possible despite having conflicts, whereby partners come together, working with government and civil society organizations on the ground to avail all the vaccines needed to and orchestrate immunization services, both through outreach and intensified efforts on the ground, negotiating access with warring parties to be able to continue to deliver vaccines. And that truly shows you when systems that actually face conflict, when they are offered the right set of support with all partners coming together, despite continuing conflict, progress can actually be achieved. And a lot has been mentioned by Kate as well about the new vaccine progress that I leave it to Kate as well to raise those.
Thank you, Ephraim. Kate, maybe over to you.
Yeah, just another point that I'd like to highlight, although it's not specifically in the WUENIC data, but is the completion of the big catch-up. And you'll recall that the backsliding as a result of the pandemic meant that there were many, many more millions of children who, during the course of those pandemic years, were left out of the immunization program because health workers were diverted to really battling, trying to shut down a worldwide pandemic. And as a result of the accumulation then of millions of kids over a period of years who were totally non-immune to all of the vaccine preventable diseases, there was a call made by WHO and UNICEF along with Gavi and other partners to undertake this big catch-up. And the big catch-up wrapped up at the end of 2025. The Gavi funding supported a particular effort in 36 countries that were most vulnerable. And through that effort of over $250 million over a period of years, countries were immunizing many more of the children who were older children, those children who were not infants but had missed their vaccines and now were 2 years old, 3 years old, or 4 years old. And it would have been those kids that would create an ever-increasing vulnerability in communities, especially for explosive outbreaks of measles, for instance. So through this initiative, more than 14 million children who were otherwise zero-dose children that kind of accumulated over these years were caught up, and more than 125 million doses of additional vaccines were provided. So it's hard to measure exactly what didn't happen as a result of all those kids getting caught up. In fact, that's sort of the peril of immunization programs, is when they're operating maximally, nothing at all happens. There aren't disease outbreaks. There aren't kids in hospitals dying of vaccine preventable diseases. But I think the wrap-up of the big catch-up has actually done an amazing job of providing further protection. The outbreaks that we're seeing today would be far, far worse were it not for those efforts. So I think that's also the good news.
Thank you. And let me see if Tamani wants to add something from Gavi.
Well, I think my colleagues have covered it pretty well, and I'll repeat myself. I'll say that the introduction of malaria is the fastest introduction in Gavi's history was particularly impactful, and we are yet to reap even fuller benefits from that. But also on HPV, we had set ourselves a target of 86 million. And we got to 95 million. That's girls and women that are protected from cervical cancer in the future. And I cannot be more excited about that.
So good. We have good news. Now we have good news. We go back into the queue to the questions there. And for all others, please raise your hand with the raise your hand icon. First question goes to Kat Lai from The Guardian. Kat, please go ahead.
Thank you very much. Kate, I wondered if you could tell me a bit more about the dropout phenomenon that you mentioned. Is it increasing, and what do you think might be going on there? What are the potential drivers? Thank you.
I think that's for you, Kate.
Yeah, thanks so much. So, Kat, this issue of dropouts has been a long-standing issue. Depending which country you're looking at, the problem can be increasing, or it can be actually getting smaller. Overall, the proportion that are dropping out is not massively changing from one year to the next, but because of rising birth cohorts, the number of children who are dropping out and not making it through the program is increasing. I think the main point here is twofold, if I can sort of point to it this way. The first is that it's those kids who start getting their core immunization, that vaccine, what we call the pentavalent vaccine, which is the vaccine that has 5 vaccines in one, That pentavalent vaccine is against diphtheria, which is an outbreak disease, tetanus, pertussis, or whooping cough, and then Hib, which is a cause of meningitis, and hepatitis B. So you need 3 doses of that vaccine in order to confer maximum protection. In fact, for some of those, any protection against those diseases. And part of the reason we're seeing the outbreaks of diphtheria around the world are because kids are not getting the full 3-dose course. And then the second part of dropout is the measles part. So those vaccines that protect against diphtheria, tetanus, and pertussis are given early in infancy, somewhere between 6 and 18 weeks of age, or 2 months and 6 months of age. And then kids wait until they're about 9 months or 12 months of age to get their first dose of measles because of the immunity that the measles vaccine can provide. And the problem with dropout to that point is that dropout is even bigger. So about 1/3 of the kids who never get a measles dose are those who are known to the system. In other words, they've gotten other vaccine doses. They just got older and parents are busier, and the program has a more difficult time delivering that measles dose. So the dropout issue, although it's not rising in terms of the proportion, it is rising in terms of the absolute number of kids. And the absolute number of kids is what's causing these explosive outbreaks of measles. Along with that measles dose, it's also the time when kids that's the age at which they also get, if they're living in an area where meningitis is a risk, and meningitis vaccine is recommended. So meningitis vaccine comes along with it. Yellow fever vaccine comes along with it at that same age. Some malaria doses are given depending on the country at that same age. So this older infant group that is dropping out from the program is missing out not only on measles, but also on the other vaccines that are given late in the first year of life or into the second year of life. So this is what our really big concern is those kids are vulnerable to all of the diseases that are otherwise being protected at those touch points for the immunization program.
Thank you very much, Kate.
If I may add, Christian, on
Yeah,
that.
sure. Come in.
I think the dropout issue is quite a fundamental issue because it shows the difference between the problems of accessing children, which is what we see through the DTP1 coverage indicator, that shows you the more 0-dose children you have, the more children that you are not able to even reach. But the dropout truly shows you that these kids have already been in contact with the system. And that shows limitation in your system of tracing these children and finding them when they drop out of the system. But it also shows that the interaction with health workers, who should be the ones to advise when parents need to return for their second or third dose, post DTP3, and even measles vaccination, or when they are not able to truly explain to parents about tolerable side effects of vaccination. And when that happens, parents do not necessarily come back. But there are also much broader system limitations as well that affect selected communities. So it is important to keep in mind that the issue of the dropout relates to much more the quality of service, our ability to trace these children when they drop out, and our strengths of the data systems as well, just on top of what Kate clearly mentioned.
Thank you very much, Ephraim, and we nearly had a dropout there with your line, but I think overall we were good. Next question goes to Nina Larson from AFP. Nina, please go ahead.
Yes, hi, can you hear me?
Yep.
Yeah, great. I have a couple questions. So just a follow-up on the dropout question. I was wondering if you're also seeing ideological dropouts, not just parents who are too busy to go in, but that they're actually deciding not to do, for instance, the measles vaccine, and how big a problem that is. And then I was also wondering, you mentioned Sudan, and I'm wondering if the big increase that you've seen there might be because there was such a big decrease when the war started, because it looks from the data like there was a very big dip, and that maybe that's why the percentage is so high. If you could just explain that a little more. And finally, Venezuela, if you could say a little bit about Venezuela, especially on the measles vaccine, but also others, because it looks like that's quite a dramatic decline. Thank you.
I'm lucky I didn't mention the one question at a time rule. Thank you very much, Nina. Let's start again with the dropouts, and then we go into the country specific. So dropouts, origin, cause, could it be ideological? What do we see?
Yeah, so maybe I'll take the dropout one, and maybe Ephraim, you can speak about the Sudan, the decrease, and then the bounce back, and we can try and tackle the Venezuela question as well. So just, Nina, I'm not sure I've ever heard the term ideological dropout, but I think we're gonna perhaps take you up on that. It's a nice phrase. I think so. A couple of things on this. Part of what we're speaking about, so what Ephraim was talking about around service provision, there are lots of reasons why kids don't come back having started their immunization program. But we also have to be clear about what doses we're actually talking about. So the dropout that we're referring to at the point of the measles vaccination is the one that we're, very concerned about. And we do see in the data that the reductions in zero-dose children or the reductions in DTP1, meaning an increase in zero-dose children, and then the reductions in measles vaccination are not always parallel. So in some settings, countries are doing the same as they were with respect to their getting kids started in the immunization program. And then there's an even stronger weakening of that time point at 9 or 12 months of age when measles vaccine is given. And we think that that is clearly related in some settings to false information, misinformation that is provided around measles vaccination. This is of very, very significant concern because, as we know, measles is probably one of the most infectious viruses and is causing deaths in children around the world. We can point to the Bangladesh outbreak that has been a really very large outbreak this year, and Bangladesh has had a very strong immunization program. An example not necessarily of dropouts themselves, but a change in government and a change in the system of the immunization program has led to a rather sudden reduction in coverage. And now, even though a program that has been a very steady program for many years, a very large outbreak, a nationwide campaign that has taken place with tens of millions of children now vaccinated and really trying to now mop up that outbreak and really squash a nationwide outbreak. So this issue of starting with a program and then failing to get the measles dose, so that's one kind of dropout, is probably the canary in the coal mine. It's where you see it first. You see measles outbreaks happen first because it is such an infectious virus. So the contribution of this, that is, as you referred to it, ideological dropout, is really hard to measure. The quantifiable, like what part of this is because of misinformation, what part of it is about false information, but it is most certainly a contributor in some communities and in some countries. And I think we also have to be clear that even if a country we are reporting national level data through WUENIC, just like when we report regional or global level, it is it's an average, and you have to look at the details underneath it. Similarly, when you look at country level data, you really have to look at what's underneath that country level, because there are very often subnational areas that have very, very different coverage from one place to the next. And it's those that are with low coverage is where those outbreaks are actually going to happen. That's where the attention needs to be placed, because that dropout issue may in fact be ideological dropout. Ephraim, maybe I'll turn to you around the Sudan question, around the big decrease that came before the big increase.
Thank you, Kate, and that's a very important question. Sudan, before the conflict, had one of the strongest immunization programs that was able to achieve in the neighborhood of 90% coverage, including with new vaccines. Right at the start of the conflict, since access to vaccines and all essential health services were considerably disrupted, immunization coverage went down quite significantly. Governments, along with WHO, UNICEF, civil society organizations, and global NGOs like Save the Children, working with Gavi, have been able to support the government to implement what they call the emergency immunization plan. And this was meant to be able to reach those children that were missed due to the conflict. And it was an effort to intensify immunization service on the ground through all possible means. This included mobile vaccination services across different regions in the country, ensuring there is adequate supply that is provided directly into the country. And there was so much support from neighboring countries as well to be able to serve as a transport corridor to avail these vaccines to children in Sudan. And this has resulted in a significant catch-up of those children that were missed due to the big catch-up initiative as well that earlier Kate spoke about, but also the additional plan and the additional funding that was offered across partners, both through emergency and development funding, including Gavi's support, have really enabled for vaccination service to bounce back. So what we have seen in Sudan is a story of returning back, a story of bouncing back after a considerable disruption. And it shows you the strengths of those kinds of systems that had already built strong primary healthcare system on the ground, workers on the ground, and when the government is committed to continue delivery of essential services such as immunization. So yes, you're right. This comeback is, of course, a result that we see after the disruption in 2024, but it also shows you the clear strengths of systems, and systems could remain quite resilient despite such kinds of conflict. So yes, 22% on measles coverage, 35% on DTP1 coverage improvement is as compared to 2024 levels, which was one of the lowest points in Sudan. But this also shows a trajectory that if services continue, if partners continue to invest in Sudan, there could be a continued improvement that could take back to the earlier coverage that Sudan had before even the conflict. The second issue, I think you raised Venezuela as well. I had a chance to visit Venezuela, and I know Tabani also had such a visit to learn about the program in Venezuela. One of the significant challenges we have seen in Venezuela has been this continued underinvestment in the primary healthcare system due to the economic challenges in the country that had resulted in increasing number of health workers leaving the country to neighboring countries, and several health facilities not providing vaccination, and government had faced a difficulty of the ability to actually buy those vaccines that used to be in the system to be able to deliver. So what we see, what we have seen so far in Venezuela is a continuation of this primary healthcare decay, despite commitment of primary health workers to be able to provide vaccination. And this continuous migration of health workers have affected delivery of vaccination across several regions in the country. And the recent catastrophe as well worsens this specific situation. Gavi can speak to some of the, Tabani could speak to some of the Gavi supports provided to the country to increase its immunization program coverage, but also reintroduce some of the vaccines that were dropped from the system due to financing difficulty in the country. Tabani, do you want to say a bit on Venezuela?
Thank you, Ephraim. I will be very brief, just being sensitive to time. I think I wanted to say that on Sudan, you covered it extremely well. One piece that I wanted to compliment you on is actually the intra-country role, where we saw Chad really playing a very important role of actually acting as a safe route for vaccines. So the intergovernmental cooperation was also very important and significant in that regard. But on Venezuela, I think you have covered the issues very well. The challenges there and the sanctions still impact the country significantly in terms of having liquid cash to operate their program.
Thank you, Tabani. Let me ask, because we have from Efe in writing another Venezuela question, not actually from El País, sorry for that. Silvia Laborio, El País Planeta Futuro. It's on the situation specifically in Venezuela again. Venezuela reported one of the lowest GDP1 coverage rates in the world, 57%, and the largest percentage point decline since 2019, which is, she says, a 28% decline. The country went from 85% coverage that year just 57 in 2025. What factors are behind this decline? And I'm going to go back to you, Tabani, first, and then we'll see who else wants to add. But everybody, please be reminded, we have 4 more questions in the queue still at this point. So let's please everybody keep their answers a bit shorter. Thank you. But over to you, Tabani.
Thank you. So Venezuela had a special investment from Gavi that was under the Mickey income and fragility support. But that investment was time-bound. It had a time-limited approach, and the hope had been that Venezuela would be able to mobilize its own resources, which they had actually identified. So when the Gavi mixed funding tailored off, what we had counted on as coming in did not come in fast enough. And so that drop is precisely a financing issue and an availability of funds being present. So that's the issue. There was a special mechanism from Gavi that was time-bound, that was supposed to be succeeded by a government investment. That government investment was impacted by sanctions, and that's why we see what we are seeing. Thank you.
We're good. All right. Thank you very much, Tabani. Then we move to the next question, and that's John Saracostos from Lancet France 24. John, please go ahead.
Yes. Good afternoon. Thank you for the briefing. Firstly, Dr. O'Brien, you mentioned 33% coverage for HPV. Your report says 31% for 2025. I'm just clarifying which is the correct number. And also on the HPV, what is the average coverage in high-income countries versus low-income countries, say in sub-Saharan Africa, to get a perspective for our audience? And secondly, I'm interested in the high number of no measles vaccine in Nigeria, Ethiopia, and South Africa, and also for DTP1, again for Nigeria, Ethiopia, and South Africa. Why these high numbers in these countries? Thank you.
Many detailed country questions. So we had HPV, we had DTP1 in Nigeria, and we had measles in Ethiopia, South Africa.
There was one part of your question, John, I didn't quite hear, but let me try and go at some of them, and then if I need a clarification, we'll ask for that. So the question was about HPV. So the number is 33% in girls. And I want to also be clear what that is referring to is the global coverage that includes countries that are not actually using HPV vaccine yet. So that's not the performance of the programs that are using HPV vaccine. It's giving us both a combination of the performance of countries with HPV vaccine and then inclusion also of countries that haven't yet. So they have 0% coverage because they haven't yet introduced. So I just want to bring forward a point there that at the end of 2025, there was a very substantial, as you know, very substantial fraction of the world's population that had access to HPV vaccine. Since the end of 2025, which is the WUENIC data, there are a number of countries, including India, that have now introduced HPV vaccines. So we are projecting that by the end of 2026, 90% of the population, so the 90% of where all the cervical cancer cases occur, those populations will now have HPV vaccine in the program. So we're headed very, very quickly towards a set of broad countries that have included HPV vaccine. And now the question is about getting the coverage up so that, yes, it's accessible, but are the girls actually getting it? So that was, I think, your first question, and so the answer is 33%. The second question, sorry, I wrote down sub-Saharan Africa, but what was the second question?
South Africa and Ethiopia, measles.
Oh, on measles. The question is specifically, John, could you just repeat the question on measles vaccine? And I think it was around Nigeria, Ethiopia, and South Africa.
I think it's a question about why coverage is lower in those places, both measles and DTP, if that's right, John.
Yeah.
And happy to come in on that.
Okay, so why is the coverage lower? So first of all, those are three really different countries, but I'll go to South Africa first. So South Africa, again, has had a pretty strong program, and in recent years has had more challenges with their program from a structural perspective, and mostly from a fiscal perspective. There are, we talk about how the P in public health actually refers to politics, and part of politics is around fiscal health of countries and the ability of countries to deploy their domestic resources across all of the health needs that there are. But South Africa has had some challenges in terms of funding its program to the degree and magnitude in order to retain the performance that the program has had. And now we're seeing some of the effects of the financial constraints that South Africa has in terms of a weakening program, and that's showing up through weakening coverage. In Nigeria, finances are always a part of the situation, but in Nigeria has a very, very heterogeneous national setting, with some states that have very high performance and other states that have performance that is extremely low, below 10% coverage. And this is largely because of a devolved system of an immunization program. Some countries have national programs and others have devolved it, so it's a state-by-state or provincial responsibility. And you see quite a bit of heterogeneity, differences across those provinces or states in terms of the performance. And Nigeria also has the issue of areas of the country that are in conflict. And so there certainly in the north are areas that have significantly lower coverage, and those are also areas where polio is continuing to be an issue of the variant-derived polio. So these measles performance issues are related not only to the capacity of the domestic resources to support the program, but also very much around a state-by-state level of performance with long-standing weaknesses. And when there have been long-standing weaknesses in a subnational area of a country, the community, the population, really loses confidence in the program itself. So there's no point, going to a clinic if over years, months or years, that clinic has not had the supplies there, a health worker there, and is not deploying. And so turning around a program that has had weakness for quite some time is a really quite challenging thing to do, and really needs to start with getting assurance that supply is going to be there, meaning both supply of the vaccines, but also of the health workers, and then changing behavior and confidence in the community. I'll turn to Ephraim to address the question on Ethiopia, as Ephraim has been deeply involved in that program coming from that country, so it would be appropriate for him to answer that one. Ephraim.
Not so sure, but happy to reflect on Ethiopia's program. And I think the recent developments in Ethiopia have been primarily related to the conflict in the northern part of the country. And over the past 2 years, access has considerably improved. And that has increased the number of children that are reached. And so the significant reduction has been able to be caught up. And Ethiopia is also one of the countries that implemented the big catch-up that enabled to reach over 2.5 million children who are even above the 1-year-old range that are normally serviced by routine immunization programs. So what you see in Ethiopia is an expansion of health services to remote rural areas that may have not been reached through regular vaccination using the Big Catch-up initiative and periodic intensification, but also targeted programs in urban areas that are not necessarily implementing strong vaccination programs. So improvements in urban immunization to reach communities and slum areas have really contributed for this improvement. And above all, the Ethiopia coverage is also heavily influenced by improvement in data quality based on the work that UNICEF and WHO have worked with the government to really distill the quality of the reports they submit through their district health information system. And that has really enabled to have an accurate estimate of their coverage that is quite higher than that they used to have over the past few years. I think it would be remiss not to really mention the impact of vaccine misinformation and hesitance in the way it impacts access to vaccination. Kate has clearly indicated some of the flavors of system-level limitations across several countries. But in upper middle-income countries and high-income countries, we are also seeing how vaccine misinformation or broader hesitance could actually impact the broader acceptance of vaccines in communities. We have systems to be able to track whenever there are such rumors or misinformations through both digital media and community level engagements. And we have been able to tailor our support to countries directed to the specific needs of those specific countries. For example, in the European region, you see a couple of countries that have seen increasing number of measles outbreaks, which misinformation has played a role in delaying vaccination by parents until the information and the concerns they have is addressed. And from what we know working on vaccine misinformation, parents have needs for information that truly understands and to be able to respond in an empathetic way. And what we have seen, can you hear me okay?
Now it's back again, but the picture's frozen.
These countries, yes, that's fine. I think, let me try my best. I think I had an outage here. So I was talking about across Europe and some of the high-income countries, increasing misinformation has actually caused a reduction in coverage since parents tend to question, and until they are able to be provided with the accurate information that is given by a trusted messenger, which usually are community influencers, and above all, people still trust providers or health workers who they use as a source of information for vaccination. So it is important we keep in mind that everything, whatever we build, whatever strong systems we have, it all depends on public trust and the confidence the public has on the systems that deliver these vaccines on the ground. And work on that is quite important. Thank you.
Thank you. If we have nothing further to add, I'd like to move to the next question. We still have 4 in line, and again, we're officially past the time, but with 4 more questions, we would like to keep going. But everybody, please, 1 question, and let's keep the answers short as well. Duri Buskarin from NPR. Duri, please go ahead.
Oh.
Now I hear something. Yes, please try.
Okay, sorry. Thanks. Hello. I wanted to see if thanks for having this conference. I wanted to see if the speakers could comment on the vaccine availability in Bangladesh ahead of this last measles outbreak and the lack of supply there and what contributed to it.
All right, thank you. Where do we want to start? Kate, you want to start, or should we go?
I think it's better to go to Ephraim because it has
Ephraim?
has a lot to do with
let's go.
UNICEF supply and whatnot. So over to Ephraim.
Yeah. So what we have seen in Bangladesh is currently the way we procure vaccines across the world is, especially for Gavi countries, all vaccines are procured through UNICEF. UNICEF works with manufacturers to avail vaccines with the best price to governments as the procurement agency or the procurement arm of Gavi. And we deliver almost 2.2 billion doses of vaccines on a yearly basis. What we have seen in Bangladesh was during the government transition, decision makers thought buying directly through procurement process, through the in-country bidding process, have been considered as the best way to maximize pricing, the best way to avail vaccines in time. So government decided they are going to do procurement on their own. This, of course, based on the experiences we have across several countries, procuring vaccines directly by countries themselves, usually, especially if they are not experienced in managing such kinds of procurement of vaccines, it usually leads to delays, and that's what exactly happened in Bangladesh. And that delay in concluding the procurement which finally ended up not succeeding, led to significant and extended stockouts. And the stockouts included measles vaccine stockouts, which of course compounded with existing shortage of health workers in selected districts and a continued disruption that has been happening in the year before, have actually resulted in this extended stockout to lead to immunity gaps that led to measles outbreak. And that's the measles outbreak that we have been responding to as partners through the government leadership. And I think credit to the government, there was quite a very strong comeback by realizing the importance of really responding to the outbreaks. And in a very short time, government have been able to mobilize both partners and health workers to be able to respond to these outbreaks very quickly and address those. We had seen about 8,000 cases that were reported in the earlier stages of that outbreak, which is quite a considerable number. And government have also, again, decided to come back to the routine procurement mechanisms through UNICEF, which will enable them to reach, to have vaccines in time. So all these challenges have been quite averted at this moment, and we have a very strong appreciation to the government for taking such a decision. Over.
That's a good answer. Thank you, Ephraim. Anybody to ask? Otherwise, we move on. Some details on government. No. Okay. Then we go to Reuters. Christy Santosh from Reuters. Christy, please go ahead.
Hey everyone, thanks for taking the question. I wanted to get a comment on what the estimate is of the impact of global aid funding cuts led by the US on immunization coverage. And also, do you see any impact in the anti-vaccine rhetoric now coming from highest levels of the US government in US vaccination rates or globally?
All right. Yeah. Global aid funding cuts and then misinformation, disinformation, and vaccine hesitancy. Where do we start?
Yeah, I'll start with the global aid funding cuts. So I want to reinforce that these data are 2025 data. And although the funding cuts are coming from donors broadly, not just one donor or another donor, we don't think that the impact of those funding cuts is showing up yet fully in the 2025 data. I think our concerns are very much for what's happening in programs in 2026 and what is yet to come. And so there are two things that I just want to say about that. The first is that we've already highlighted for you that the predominant zero-dose children problem, the number of zero-dose children, is largely in countries where those country immunization programs are being supported through the Gavi Alliance. And so the funding of the Gavi Alliance is extremely important. That funding supports the procurement of the vaccines for those countries. Not all of the vaccines. Those countries are still procuring on their own some vaccines. But a large fraction of what those countries have in terms of just the vaccine commodity is coming through a Gavi funding channel. The fact that Gavi did not fully replenish for this 5-year period means that countries are going to have to make, and they're making them this year, make really difficult decisions around how they're going to tailor, meaning constrain their programs going forward. So the first thing to say is that the global funding cuts have not shown up yet fully in the data because they haven't fully shown up in the country programs. The second thing to say is that we are already seeing the impact of some of these things. We are seeing unprecedented numbers of outbreaks, more measles outbreaks, more diphtheria outbreaks, more cholera outbreaks. So all of these, the pressure on the stockpiles for outbreak responses has been very, very considerable. So this is exactly what is already starting to show up as a result of the step back from official development assistance. And then the second issue is that countries are very much being called on for more stepping forward further in terms of a self-reliance approach and having more domestic funding. But I'd like to point out some data that's not from WUENIC, but just points to the stress on these countries. About 3.5 billion people live in a country where the country spends more money servicing the interest on the debt than the country spends in the entirety of their whole health program. So this call from the world that lower income countries should be spending more on health of their own domestic resources is a much bigger issue than just an immunization issue or even a health sector issue. It's a big financing issue that the world is going to have to tackle together. There isn't space for those countries to do very much in terms of increasing their domestic funding into their health programs, let alone deploying that primarily into immunization, although we do think that that is a best buy. In fact, the evidence says that immunization is one of the most cost-effective things to do. The return on investment is one of the highest returns on investment. And so if you want to spend money wisely, you would put it in the immunization program. So just, I hope that addresses to some degree your question about are the global aid cuts showing up in these data? They're starting to show up, but we have certainly not seen what the possible impacts of those funding cuts are going to be on immunization programs. Those are, I think, yet to come. And we're very, very concerned about what the 2026 outlook is going to look like. We'll all be here a year from now giving that readout. And then the second question is on the anti-vaccine rhetoric and the misinformation and disinformation. Why don't I give a chance to Ephraim and Tabani to say something about that?
Let's start with Tabani because he also wanted to add on the funding, and then if you can take something on hesitant misinformation.
Thank you very much. Thank you very much, and I think Kate really covered the breadth of it there. But I wanted to say that some of the choices that we are making already, we are aware that they are going to have an impact down the road. And we have some figures in terms of estimates that speaks to that. We believe that 600,000 lives that could have been saved will be impacted by this right sizing and trying to fit to the wallet that we have. We also have seen a program that we were just celebrating a moment ago, which is malaria, actually needing to curtail the number of children that we will be able to reach, where we've had to cap the coverage. That's something that we did with heavy hearts, and countries are still looking at their options. But we know that it may be a very difficult one to achieve. Then in terms of our own priorities, we are working with countries on a very concerted effort that is focused on domestic financing to make sure that that area is accelerated. But even with the best efforts, the fiscal cycles and the budgeting does mean that there will be gaps, even if we were to be successful. Thank you.
Thank you very much. And we want to get to Ephraim to see about the last point we had.
Yes, and just one addition on the funding. Even though we are not seeing it on 2025 figures, the impact on the global public goods, for example, our ability to have a strong surveillance of outbreaks have been considerably impacted as WHO, UNICEF, and global partners working on this just right in 2025. And even surveys across countries have also decreased in number as a result of these funding reductions, which further also impacts the quality of the estimates we do on WUENIC. So it's important to recognize that even though we don't see the numbers already showing up in the 2025 estimates, the impact of funding cut is already affecting some of the work we do at a global and regional level. On vaccine, anti-vax sentiments and senior leaders making comments whether it's impacting broader immunization coverage, I think it's important for all of us to agree that voice of leaders, both political and community leaders, it's extremely important in influencing parents' decision making. It is really important that leaders take responsibility and exercise a sense of accountability whenever they communicate, whoever the kinds of leaders are, because their opinion really influences how people perceive vaccinations. And so our entire work, we have worked with leaders at different levels, community influencers, to really strengthen trust on vaccination. And that is an important work that needs to continue going forward. For a child to be fully vaccinated, it's not only the trust and the misinformation or the vaccine hesitance that really matters. The first starting point is the availability of vaccination itself, provided by a well-trusted health worker and delivered quite closer to the communities who needs it. And communities that have trust on these vaccines could be able to come and take these vaccines. So the primary problem we have at this stage within the immunization program, in light of conflict and fragility, in light of challenge that countries are facing to really finance their immunization programs, is actually availability and access to services, even though misinformation and disinformation is still an important topic. So all in all, to say, it's hard to link a particular narrative to an immunization coverage, but I would like to underline the importance of responsible communication for all leaders at different levels. Thank you.
Thank you all very much. And now we have time for one more question. And I'm already apologizing for all those who we can't get to. The puzzle is rolling. Priti Patnaik, Geneva Health Files. Priti, please go ahead.
Hi, thanks for taking my question and for this briefing. I had a question about Palestine. If you have seen how immunization efforts may have suffered in the last couple of years. And on the question of Sudan, every conflict is different, and WHO and partners overcome different kinds of challenges across conflict settings. But are there any lessons from Sudan for other conflict settings as far as immunization is concerned? Thank you so much.
Thank you very much, Priti. And let me see who we want to start with. Ephraim, maybe you want to start?
I think on the Palestine case, what we have seen over the past 2 years is there has been a disruption of immunization services along with other essential health services. And partners, WHO, UNICEF, and Gavi have worked together to be able to find ways of, one, continuing immunization services despite ongoing conflict, but also being able to provide the service needed and being able to reach those children that were missed through the routine immunization system. Together, we have done 3 rounds of what we call intensification of immunization, which is basically using mobile clinics and increasing the number of health service delivery points amidst of the conflict to be able to catch up with those children. And through 3 rounds of this intensification, we have reached over 50,000 children that were missed or were not being able to be vaccinated during the conflict period. One important reminder is the state of Palestine has already a higher coverage rate from the period before the conflict, and have already a well-established and very strong trust by communities to take vaccines. So we are building on that existing foundation as we do this catch-up initiative through the previous 3 rounds we implemented. And the success in doing as well polio campaign during the conflict is also one show that continuation of health services will remain essential despite ongoing conflicts. Over.
Thank you, Ephraim. And Tavani wanted to add? Yeah, please.
No, thank you. I just wanted to recognize that the Gavi board has made important decisions around fragility and countries like Palestine that allows us to continue to be able to support them with the Gavi resilience mechanism. And this is particularly important while they continue to figure out what funding channels and options they have as they come out of the recovery phase. And as Ephraim has noted, it has been a very resilient system, but also a high demand for vaccines as well, where the vaccines were quite demanded by the community. And what we really needed to deal with was access and making sure that the vaccines were available.
Thank you, Tawani. And I think Kate wanted to add on Sudan.
Yeah, just you asked the question about what lessons can we draw from Sudan. And actually, I think it comes to also a lesson from Palestine. We've seen this throughout the recovery from the COVID pandemic also. Countries that already have a program that has been performing very well for a substantial number of years, they're not immune to a shock. In other words, when a COVID shock, a pandemic type shock happens, or a conflict setting happens in a country, it doesn't mean that the program does not actually experience that shock. But the point is the ability for the program to recover very quickly is much stronger in countries that have built their program year in and year out to build that resilience in the program. Resilience really looks like a country that has health workers who are very capable of delivering an immunization program, a community that values immunization and seeks those services day in, day out, month in, month out, that it's valued, a political sector that has actually domestically funded the program for years and funded it to grow and to build and to be strong, and that there are technical people in the country who are advising on the best design of the program for that particular country. That's what we call resilience. And so the resilience does not protect from the impact of a shock, but it does provide this rapid rebound back to a performance level that the country had before the shock happened. And that's what we see in Sudan. It's what we see in Palestine. We've seen it in a number of countries with different shocks that have happened. By contrast, a country that has struggled to actually have a program that is high performing, when a shock hits, it takes much longer, and it may take years for it to recover back to even the level that it was performing at before the shock hit. So I think these are the lessons. And at the very top tier of what builds a resilient program are two things. One is the political commitment, the political will of the leaders to actually put resources into the program and to speak publicly about the importance of immunization. And the second part is the community engagement in seeking those services. And it's not that complicated, actually, but those are the primary reasons why when programs aren't performing, you always find those as deficits in a non-performing program. So just if we're going to wrap up, Christian, I think we're quite over time. I'd just like to wrap up with one comment, which is really that first of all, we deeply appreciate your coverage of this report and the coverage of the immunization issue. As a group of adults on this call, I would venture to guess, although I've never seen your personal immunization records, but I would venture to guess that virtually everybody on this call is a vaccinated person. And we have had the benefit of vaccines that have been deployed worldwide. We are seeing real cracks in the system now for immunization, and we are previewing big risks that are yet to come. In the face of that, there are big stories about success and resilience, and I think those are just as important to tell. But for every child that misses a measles dose, as an example, they are not only susceptible to measles. Each of these diseases provides additional risk for other diseases that themselves are vaccine preventable. So missing a child who has dropped out, or a child who is a zero-dose child, is not only susceptible to those diseases for which they weren't vaccinated. They are now additionally susceptible to a series of other diseases that come in the wake of the illness that they may survive, but will put them at risk for the next disease. So we have a strong responsibility as the voices of evidence to tell these stories in ways that will activate action.
Thank you very much, Kate. And you rang in the round of the closing comments. Let me ask Tawani Mafosa from the Gavi Vaccine Alliance for some closing remarks.
Thank you. I think I'll speak in two dimensions. The first one is that the UNIC results show us what is possible with a fully funded Gavi. We have made progress, that progress is one that can be replicated, but with the increasing birth cohorts that we mentioned, we need more resources to be able to keep pace with what is required. And so I do want to really end by saying that the funding shortfall that Gavi has is one that needs to be highlighted, because the celebration that we may have in certain areas in Gavi 5.0 or in the period that we're just reporting on is in part due to sufficient resources. And we are going into a very difficult period where there is a funding gap. And this is not only to be filled by Gavi, but also really thinking about the Accra Reset Agenda, where Africa and others are taking domestic financing more seriously. And would say that the test to actually move forward with some of these and step up domestic financing is now. Thank you.
Thabani, and last but not least, Ephraim Lemango from UNICEF.
Thanks, Christian. I also want to speak on 2 points as a closing remark. I think for everyone on this press release, it is important for all of us to keep in mind the gains that we are celebrating now at this moment are quite fragile. And what we have seen over the past 2 to 3 years period with conflicts and fragility is that these gains can be eroded very easily. So it is important for all of us to be the voice to maintain immunization coverage and improve immunization coverage, and serving as the champions to speak in favor of vaccination, as it is one of the most proven public health tools that save lives. That is one. 2 is, despite the successes, we're still far off where we should be in 2025 and where we intend to be by 2030. So there is a need for us to accelerate our performance. There is a need to reach those children that are in the trenches of conflicts. There is a need to reach those children that are in remote rural areas that are not being reached. And we need to be able to get to those children that may not be vaccinated because their parents still have questions about the effectiveness and safety of vaccines. So this effort will need to continue and need to be accelerated until we get to the target we have by 2030, which is reducing the zero-dose children by 50%, and of course, achieving that 90% coverage across different vaccines. So the road ahead of us still requires us to do more. Over.
Thank you very much, Ephraim. Now, with this, we're coming to the end. And that was Dr. Ephraim Lemango, Associate Director for Health and Global Chief of Immunization at UNICEF. We had Thabani Mafosa, Chief Country Delivery Officer at Gavi, the Vaccine Alliance. And we had Dr. Kate O'Brien here with me, Director of the Department of Immunization, Vaccines and Biologicals at WHO. I thank you all very much, especially for staying so long over time. Any other pressing questions? There's a chance tomorrow at the DG press briefing. We have a press briefing announced already globally, virtual, with the Director General. And Dr. Kate O'Brien will be part of this one too. So that would be tomorrow, 3 o'clock, 1500 hours, Geneva time, here in the afternoon. From this one here, the embargo is still another 10.5 hours, another 10.5 hours until shortly after 2 o'clock in Geneva, Central European summertime. We still owe you the press release. I believe strongly this will come to you before the end of the embargo. And with that, thank you all very much for joining. See you next time.